So we are delighted today to have Dr. Rosie Frasso to give us a talk. Before I introduce our speaker, I'm just going to go through the housekeeping elements. So please make sure that you sign in. Please RSVP so we can better prepare for the next session, and it's mostly for the food, so that you can have your food. Online participants, please keep the mix muted unless asking a question, and please keep the video turned off. Use the chat feature in BlueJeans if you have technical questions. Next, we don't have any talks next week because many of us will be at the Center for the CTR, the ACCEL CTR conference at the University of Delaware. But on March 4th, we'll have our own Paul Cohn do the use and misuse of statistics in medical research. And then we'll have a talk by Yukiko Washio on March 11th from Maternal and Infant Behavioral Health and Nutrition, and her talk is Incentives and Mobile Technology in Community Settings. So you can see all the full schedule on the ACCEL website, and all the previous presentations are available also on our website. So Dr. Frasso has a PhD in social welfare from the School of Social Policy and Practice from the University of Pennsylvania. And before that, she has 2 masters from Harvard School of Public Health, one in maternal and child health, and another one in Science in Society, Human Development and Health. She's currently the Director of Education in the Master of Public Health Program and the Center for Public Health Initiatives at University of Pennsylvania. She's faculty in the Mixed Methods Research Lab in the Department of Family Medicine and Community Health, and also she's a Senior Fellow in the Center for Public Health Initiatives. Early in her career, and we just talked about that, Dr. Russo was a trained echographist. And from 2002 to 2004, she was a consultant for the Massachusetts Department of Public Health in Boston, in the Office of Health and Disparity. So you had already decided what type of career or research that you wanted to do. And her project there was mammography access related project. She currently teaches at the University of Pennsylvania School of Nursing and the School of Social Policy Practice, and also at the School of Medicine for the Master of Public Health. She has multiple publications, projects using photo elicitation techniques, and I would love to learn about that because I don't know anything about it. She has mentored multiple graduate students and is also an artist, and created artwork for the Hopeful City
Where did
artists.
you find that? I'm so impressed.
For build Hopeful City artists for build a bridge project, and so we are really looking forward to your talk and to learn more about those.
Don't ever look for that painting, it's terrible. In any event, thank you so much for that kind introduction, and I'm really excited to get a chance to talk to folks about qualitative methods. And I want to start off by just telling you a little bit about Penn's Mixed Methods Lab so you'll understand where I get off talking about this stuff. So at the University of Pennsylvania, we have this lab with a dedicated team of faculty that are engaged in using qualitative methods to augment and integrate with quantitative methods with clinicians across the university and really around the country, looking at ways to try to think about their work differently and how to integrate the qualitative approaches. So this slide deck today kind of goes through a lot of information, and I wanted you to have it as a reference even if we don't get through all the slides. So if we have questions as we go along and we just have more of a conversation, that's totally fine with me, and you'll have this to flip through at your leisure, and you can always reach out to me. I'm going to take a minute just to introduce my research assistant. She and I work really closely on 1 million projects. She's a great asset and resource. So if you decide this is the kind of work you want to do, reaching out to one of us, we'd be happy to help. So let me get started. I want to talk about what's sort of in our toolbox in the qualitative arena. And people are pretty familiar with the interview and with focus groups. But there's lots of other things that we do in the qualitative arena, and really creative and sort of empowering ways to engage participants or patients as collaborators in the work we do. So we'll talk very briefly about all of these, but if there's something that really floats your boat and you want to talk more about, let me know and we'll focus on it a little bit. So in the individual arena, we have things called cognitive interviews, key informant interviews, photo elicitation work, walking interviews, and Relisting, which is an anthropologic approach to gather perspectives really quickly. It's a really nice way to look at phenomena from multiple. And in the group methodologies, we have the classic focus group, the nominal group approach, and Delphi groups. And I want to say first that when I get approached by clinicians, they always want to do focus groups. No matter what the topic is, like, yeah, we want to do focus groups, we want to learn more about this. And I think part of that comes from this desire to have a bigger end, you know, to sort of feel like you need more participants to really appreciate what's happening. And so I want to say that I spend a lot of time talking people out of focus groups, because it really depends on the question you're asking, what approach is the most appropriate and what approach will be most effective. So we'll just tease through some of that stuff today. Things to consider when you're deciding to use qualitative methods is really timing. How much time do you have to do it? What is the timing of the study if you're integrating this into other work? Or sometimes qualitative methods are a great way to begin and just start to explore a phenomena, an experience, a patient's perspective, and just get a sense of how much time it needs. The feasibility is really important to consider, and we're going to talk about some of the challenges of doing this work. The topic has to sort of fit the method that you're picking, all these different data collection approaches. Of course, you need access to participants, and sometimes we don't have that. People have wonderful ideas, but no way to get a hold or get in touch with or connect with the people that know the thing you want to know. Sometimes there's a need for anonymity or confidentiality, and that will dictate what method you do. Focus groups aren't great if you're promising your participants confidentiality, and certainly you have to be thinking about the study goals in general. So the first decision to make always is to figure out what it is you need to know, to sort of sit and ponder and think what it is you're trying to understand. And then think about who knows what it is you need to know. And then that's sort of that second step. And I say this, it sounds very simple, but it's exceedingly important because people don't take the time to think through these first few steps before they begin. And the third decision is what is the best way to learn what you need to know from the people who know the thing that you need to know. And that takes a little bit of pondering. And finally, what's the most effective and appropriate way to engage those people, who they are. So let's talk just quickly about cognitive interviews. Is this a concept or a construct you've heard of or familiar with at all? No. So cognitive interviews are really used primarily at sort of the beginning of survey development to make sure that you're building survey questions, close-ended questions, that are really getting at the constructs that you think they're getting at. And people tend to jump from trying to understand something to a survey without really pondering sort of how their survey will be appreciated or understood by the community or the population that they're trying to engage with. So the example I always share, which is a very, very obvious one, is surveys that include terms like, you know, tell us how you're feeling today. And the response questions are, I feel blue, I feel this, I feel that. When blue may not mean something to the community you're engaging. Blue might mean something to you as a researcher, or you as a psychologist, or you as someone who's working with patients from a different perspective. But needing to know whether a color really encompasses the meaning of a mood or a feeling is something that people really skip that step. And I've seen so many surveys that, you know, people put so much work into developing them and so much work into using them and then gathering the information without really wondering or spending the time up front to make sure the questions are of value in certain communities, especially the communities they want to avoid them. The other approach is key informant interviews, and this is one of the many interview approaches, but it's the one we are most familiar with, and certainly when I talk to clinicians and folks in the healthcare setting, they're doing or interested in sort of figuring out who knows something and knows it well, and how are you going to talk to them. And I'm going to go through an example of when we've used key informant interviews. Walking interviews are a cool strategy where you actually go on a trip. You share an experience with a participant, you actually walk through their day with them as they interact with your healthcare system to really talk to them while they're doing it, as opposed to asking them to reflect on it later. Very time consuming, but very rich data comes from them investments in data collection. And we'll talk a little bit more about relisting. So again, cognitive interviews are widely used for survey development. There's 4 stages of this approach, looking at comprehension, information retrieval, judgment formation, and response editing, so that you are sure your questions land the way you intend them to land in the community that you're trying to. We're going to talk a lot of different approaches, but sort of I want to show you the menu and then see what it is that kind of gets you excited. Key informant interviews really focus on an expert's understanding of an event, a process, or a phenomenon. And when I say expert, this may be your patient that's struggling with a chronic illness, a diabetic who's really trying to examine his life and think a little bit about how to manage that illness, and they become the expert. Or it's a clinician who's servicing patients with a certain set of criteria or diseases or pathologies. Or it's the social workers who are engaging with people in this setting in your organization. The key informant interviews allow you to really explore the unlocked information. They give people a chance to really share and tell you what's happening from there. And we don't usually take that time in the clinical arena. You don't have it. So it's nice to be able to design studies that allow you to appreciate that sort of for patients like the ones you're treating, so that you can have that perspective with the patient in front of you. And I think that before I get too much further, I think what's really exciting is that we're seeing qualitative papers show up in lots of literature in all kinds of places. We've just got one accepted into radiology. It's a bit of a miracle, frankly, because if there's people that like numbers and images, it's those radiologists, and we sold them this qualitative paper. And it's really exciting that it's really being embraced in lots of different places. So you want to make sure that you're speaking to people that are affected perhaps by the proposed policy change or program shift, people who make the decisions may be the key informants, people who process or have a different point of view about something, or they have a different perspective, one that you really need and don't know. They know a great deal about the issue, they've had that experience, or you're trying to get differing vantage points. You know, what do older patients perceive as this experience, and how do younger patients? You might want to talk to both of those extremes on the spectrum to get a good handle on how you're providing a care service. We've done a lot of work where we've spoken to patients, caregivers, clinicians, and social workers trying to get at an understanding of all the folks that are interacting at the same time. Or we've talked to parents and pediatricians about a different phenomena to try to understand where they sort of appreciate what's going on. So I'll give you an example of a study I've worked on with a radiologist at Penn, Dr. Hannah Zafar, and she was really interested in understanding what happens when clinicians, primary care docs in particular, get a radiology report, and in that report is the dreaded incidental. And then you're stuck because now it's landed on your lap. And what informs what you do next, and what do you want from radiology as sort of a provider of a service to you? And there's all kinds of conversations sort of interdepartmental about this experience, but there hadn't been really an opportunity to study it, from the outside to really get a handle on what it was that folks wanted. What sort of started happening once that report showed up on your desk or in your computer or in your queue, and how do you deal with it? So we interviewed 30 PCPs, and we talked about their experience managing and following patients once an incidental finding was reported. And they talked about patient-level factors that sort of influenced what they did. So if they had a particularly litigious patient, they may disclose the finding. If they had a patient who was elderly and had other comorbidities, they may not share the finding or may not work it up. So there was all kinds of things at play at the patient level. They talked about their own perspective. If they're new, young, just got out of training, they tended to be a little more aggressive with their follow-up of an incidental finding.
Attention, please, trauma alert, emergency room 8, patient in. Attention, please, trauma alert,
okay. So anyway, provider perspectives, and what are the things that they brought to the table that influenced how they dealt with it. Experience was a big one, and also sort of their comfort with getting those reports and their own reflection of what had happened in the past when they didn't act on an incidental finding, or if they had. And then there were sort of these factors about the actual report itself, the way it was worded, what part of the report the discovery was shared in. Was it in the body of the report or in the impression? Was it highlighted in bold? Did it seem like the radiologist was hedging a little bit? Did they provide differential diagnoses? It was really interesting. The report itself really drives some of the response to that finding. And then radiologist factors. How well do you know the signing radiologist? Is this somebody you have a rapport with? Is it someone whose reputation you can sort of think about? Was it a resident? Was it a fellow? Was it the neuroradiologist who was covering for the weekend and now he's talking about an appendicitis? You know, and how does that influence how you act based on who it is that's reporting? And then sort of issues about the finding themselves, talking sort of whether cystic findings were more comforting or less worrisome than things that were complex in nature. So just having some time to talk to PCPs about what informs what's going on. And this is, you know, we're actually writing 2 papers about this. Some of them are potentially modifiable factors that can improve the PCP's experience navigating the finding. All qualitative work, and I think exciting because it wasn't something that radiologists had on their radar, frankly. I hope I'm not offending any radiologists. So walking interviews are a very different approach. Like I said briefly, very time consuming, but it allows people to reflect on an event and experience while they're having it. So instead of bringing people together and doing an interview or doing a focus group and saying, tell me what it's like to come to the hospital with your elderly parent, with the challenges you face when you do that. You have a research assistant or a scholar, a researcher, walk through that day with a patient and really get a handle on what the obstacles are. It's really very different to reflect on an experience than to sort of be there and ask questions in real time. It's not an approach for the novice. If you've not done in-depth interviewing before, you don't want to start off by walking and doing an interview. You have to know yourself as a scholar and as a researcher whether if you can't walk and chew gum, this isn't the approach for you, because you really do need to think on your feet with a walking interview because you don't have the same set of prescribed questions. You want to be able to react to what's happening in the space and ask questions that make sense. But it can provide a very in-depth appreciation for the patient experience. Sure.
Oh, yes. So for the walking interview, do you go around with a microphone and,
I'm going to show
and
you what we do. Yeah. So I'm going to tell you a little bit about a study we've done with urban shoppers responsible for feeding families. And this is sort of my little argument for walking interviews, in that you don't rely on reflection. You get to ask these questions in real time. But let me show you the logistics. So this is one of our MPH students and not a real patient. But he's wearing a lapel microphone and a lanyard and an audio recorder. And we did this big study in the grocery stores across Philadelphia. And when we decided to do this, collaborating with the health department, be a little quirky. We're going to walk into the grocery store and they're going to be staring at us and thinking, what are these people up to? And I want to say this, nobody cared, because everybody's on a device at all times. The weird people are people that are alone, not talking to anybody, not hooked up. Like, you stare at them now. You know, we used to think all the people that were talking to themselves looked a little crazy and you wanted to get them help. But now it's like, oh, that poor sucker has no one to talk to while they're looking at fish. They have to look at fish by themselves. So, I mean, it's very interesting. People, no one noticed. So both the interviewer and the interviewee are using the lapel mic and audio recorder and using lanyards that we're all been given at every meeting that we never knew what you can do with your lanyard. But the approach is really cool. I mean, there's definitely challenges. If you're walking through a space, there's noise, there's things moving, there's walking and talking is something you have to be good at. Walking and thinking about what questions. There's obviously some social desirability bias. People may do things differently. We were worried a lot about this in the shopping supermarket study, because we were afraid people may make different purchases because we were hanging out with them. What we found actually is that the folks that we were talking to, their budgets were so tight that they weren't going to adapt their shopping trip to meet our needs. They were really interested and excited to hear and to be heard about what are the challenges they were facing. And you have to ask questions very carefully. We asked them, we met them in the parking lot, we invited them to participate in the study, and we said, we're really interested in your shopping experience. We're trying to really get a better understanding of the challenges people face when they shop for their families. So we weren't saying we're trying to see what kind of healthy foods you buy. We never went down the, oh, this is healthy, this isn't healthy road. We learned so much being in the supermarket. And we talked to folks. Yeah.
Do you walk in with a series of questions already kind of in the back of your mind that you want to ask, or is it just total blank slate?
So true qualitative research is depending on the nature of the study. The level of affinity in terms of the questions you ask varies some. With these walking interviews, we wanted to leave it pretty open. So we had 4 touch point questions we were asking. Tell me about your experience. Is this a routine shopping trip for you? And a couple of other things. But for the most part, we were developing questions as we reacted to the shopping experience. We learned so much. And I think one of the most fascinating things we learned is we were talking, the issue of healthy food came up as we were in the supermarkets with people. And we have all our own assumptions about what healthy food is. Fruits and vegetables, we want it to be fresh, we want it to be, available and ripe and ready to eat. But when we were in the supermarkets with folks and we were talking about their choices they made, they were opting for frozen or canned fruits and vegetables because the fresh stuff wasn't healthy. And it wasn't healthy because there were rodent droppings in the displays, or there was fly paper there. So there were all these things that we're not used to seeing in Whole Foods or in some of the places where we may shop. But in these community settings, when people don't have choice, they're shopping by foot, they can only go to the places that they can go to. They had to redefine what healthy meant, and healthy had to fit their experience. And I don't believe that had we not been with them in the grocery store, we necessarily would have appreciated some of those barriers to making what we perceive as healthy choices. So it really allows you to have this opportunity to be in a space and appreciate it. In this particular study, we did a combination of focus groups and walking interviews, and we did the focus groups first. And then we augmented that study with the walking interviews. In retrospect, and from this moment on, I'm recommending it in the other order. Because had we gone shopping with people first, we would have written better focus group questions because we had that perspective. We might have asked about those kinds of things in terms of fly paper and mouse traps and things that we hadn't anticipated. And this is a bunch of people that really think carefully and a lot about food and food access, and it just hadn't occurred to them. That the definition of healthy really had this issue of sort of sanitation and the status of the grocery store's sort of pest control capacity, which varied a lot. Yeah.
Were you able to enroll a lot of people into the study? I mean, were they agreeable to participate?
Yeah, we had, I have to say, by and large, especially marginalized communities, they want to be heard. If you invite them respectfully to be collaborators in this work, if you invite patients to help you do a better job, they want to be part of it. They want to be part of making a difference. We had no trouble getting participants ever for this, especially this particular grocery store study. We turned people away at the focus group because so many people feel so bound by this geographic access to food and really wanted the health department as their sort of umbrella organization to provide them healthier and better access. So it really wasn't a challenge. I mean, there are times when it has been, but not here. We offer very moderate and respectful incentives, and we had to think a little bit about whether the incentive would change the experience. So we didn't provide the incentives before. These are actually not actual consumers. These are students I made do this, which is so fun in my job because I can make them do stuff. Not all of them, not you, Allison. You took these pictures, I think. But I wanted to be able to show people what the experience was. We didn't photograph the actual participants. But I think for the most part, people are really struggling and they want to be heard. And if you invite them in a way that is respectful and truly mean what you say, like we want to do a better job and we can't do it without spending some time understanding your experience. Very few people will say that. I mean, that's just been my experience. Even the PC like, oh yeah, we want to talk about those incidental finding reports. And those are busy folks. I mean, they've got their huge, patient slate that they need to take care of, but they're frustrated. I mean, that's the kiss of death. There's a little ditzel on the kidney. What are we going to do? They want to work better and more efficiently, and they wanted a chance to share with the discipline of radiology what it's like to be on the receiving end of a report that's a little bit hedgy and complicated to engage with and interpret and react to. So I think one thing that we didn't find as an issue really was this: we were worried that people would sort of accommodate their shopping trips based on us, and that really wasn't. That's a risk with all of this work. It's a risk with surveys. People will tell you what they think you want to hear on a survey. It's a risk with interviews. It's a risk with focus groups. And you need to ask the questions in a way that uncovers that the truth in the story. And sometimes you need to ask questions in a couple of different ways to make sure that you're getting at the truth. And that takes some experience and skill and practice. But for the most part, we feel like we've learned a ton doing this work. So with the shoppers, I wanted to just point out that we learned different things from the focus groups than we did from the shopping experience. So the themes that arose just in the focus group and didn't come up in the shopping experience are in this green circle in the Venn diagram. The things that just came up in the walking interviews are the far left, and the places where they were overlap or in the middle. But again, this was one where I think we kind of misfired in terms of timing. I think we learned a ton from what we did, but I think we could have learned more had we done it in the reporter. I'm working with a PhD student now who's doing walking interviews with children coming home from school in communities that are pretty violent. Sort of talking to them about their experience and exposure to violence, how they think about it, and if they think about it when they're walking home, and how it changes the path they're up to. Really interesting work. And again, they're bringing these kids together to talk about it in a focus group setting, but being out there with them as they make decisions on the fly really gives us some that can help us ask better questions, either in a quantitative survey or in a focus group setting, or even in individual. So again, the logistics, in the old days, this equipment would have cost a fortune to do it and do it well. I think these lapel mics were $19.99. Granted, I bought them at Radio Shack, and that no longer exists, but you can get them online still relatively inexpensively. But the equipment is really accessible, and I think that that's something that makes some of these creative approaches a little more accessible. The public is totally desensitized. Nobody cares. So let's talk a little bit about photo elicitation. Is this something people have heard of or touched upon? Yeah. So what experience, what knowledge of it do you have?
We actually try to do some of this with our Medical Home Without Walls program, which was a community outreach for high utilizers of medical care, where we sent social workers and nurses to the homes to work with them for a period of time. And they were actually, some of the participants were given cameras to walk around and take pictures, and unfortunately they were never analyzed. Okay. The people who started the program left, and so we never actually, it's good, I probably could go back and get those cameras.
Yeah. So the photos, depending on what you're going to do with these data, the photos themselves are not necessarily the data.
Right.
What the photos are this tool to engage in the conversation. So the way we've used it and the way I've seen it work well is that you engage with participants. We're really trying to understand your experience with X, Y, or Z, and I want you to think about it over the course of a week or two. And whenever something comes up that's related to that, take a picture. Then we'll come back and we'll talk about those. And so the pictures become a way, the act of taking the picture becomes a way of priming the participant to think about and focus on what it is you're interested in and what may behoove them for you to have a better appreciation of. And it also provides you a great frame to have a conversation. What's going on here? Tell me why you took this. What's happening? How does this picture impact how does this picture represent something that impacts your? So the picture becomes this great conversation starter. And then the pictures can be really useful as a dissemination tool, embedded. But you can code and analyze images. It's not something I've done, nor have I found particularly fruitful. But actually using the picture to sort of just lead the discussion and empower the participant, it's been really an amazing. And now again, like these everybody's walking around with a really good camera all the time. Even very marginalized folks have really cool phones. And most phones can take pictures. And you can get very inexpensive disposable and digital cameras. So the work used to be a big endeavor to sort of equip someone with a camera to do this and do it well, and now not so much. So people are doing a lot of it just relying on technology that people are. So smartphones and cameras are accessible. You can ask people to bring in and think about pictures that exist, or you can focus on a newspaper article, or you can explore Facebook with a patient, or a client, or a participant. Get at some of the things that help them stay healthy around social networks and social support, cartoons or family photos. I want to tell you a little bit about a project that has been done by Dr. Galatru at the VA Medical Center. If you're not familiar with her work, take a look at it. She and I collaborate on a lot of projects. I wasn't involved in this one, but it's so special that I'll share it with you. So she did photo elicitation work with veterans who were returning from deployment in Iraq and Afghanistan, trying to understand what about their deployment and their re-entry into civilian life, what about those experiences impacted their ability to navigate and use the healthcare system. And what was going on? What was affecting their health, and what was happening that sort of kept them from staying healthier? The suicide rate among veterans is exceedingly high, so digging in and understanding what was going on and what their experience is like was really valuable. So she has a beautiful website where some of the images that the veterans shared are there, and you can take a peek at that. This is NIH-funded work, and what's great about it is that she's taken the photo elicitation technique, which is using the photo to just engage or start the conversation, and using it as a way to keep participants as collaborators. So the veterans that were part of her study work with her in both the dissemination of the work and also in the interpretation and analysis of the work. So they stay on the team as pretty time-consuming stuff. The veterans travel with her and the photo exhibit around the country. I've got veterans who've worked with her come to my research class and talk about their experience as how much it meant to them to be a participant in this study and how valuable it was to reflect on images in concert with a researcher. So again, the approach really primes your participant to reflect on what it is you're interested in and what may behoove them. It gives you that chance to have a rapport that isn't staring someone in the face, but focusing on something else. And it really allows you to enhance your dissemination. Very powerful picture. The other group that has done this and done this really well and worth kind of looking at is Mariana Chilton's group at Drexel University. So she's done photo elicitation with people across Philadelphia, looking at the challenges of feeding. Really powerful stuff where they've imaged their experience over and over again about the things that come to mind or are challenges when they're feeding their food. I have a picture that she shared with me that I don't have in this slide deck, but it's a woman in front of her refrigerator, and it's full. And I always ask my students, what's going on in this picture? This woman standing there showing her refrigerator and freezer open, packed to the brim. You couldn't get another thing in there if you wanted. Oh, she's taking food out for dinner. She's getting ready to prepare her dinner. She's looking for ice. She can't find the thing. They have all these different ideas about what's happening. And what's really happening in that picture is that there's so many rats and roaches in her apartment that all her garbage is in the refrigerator. So she has to fill the refrigerator up with garbage, and she doesn't have any place to keep fresh food. So she's talking about one of these barriers to feeding your family that we wouldn't have, with this kind of work, it's sort of like the questions we never would have thought to ask. Like, I don't think I ever would have said, so, what you got in your refrigerator, food or trash? Like, it would not have occurred to me. And I fancy myself a thoughtful, person. We don't know what these experiences are like. You don't know until you ask people to say, hey, I want you to think about feeding your family. When something comes to mind, take a picture, then we'll talk about it. I think if we brought her in for a focus group, that might have come up, but I don't know that we would have asked the question to get there. I just don't know. And these methodologies give you a little sneak peek of a lived experience. They're time consuming. So if you're working and taking care of patients and you're a clinician trying to figure out how to best integrate qualitative work into your discipline or into the work you do, trying to understand what the numbers mean, you have to maybe think carefully about which approach is best, but I wanted you to know what's on the So these are some other examples of photo elicitation. This is work I've done with students at Penn. Penn, like many of these universities, these students are struggling. They're struggling with stress, anxiety. We had a really rough couple of years with the suicide rate very high. So we did some work looking, talking to students and thinking and sort of exploring issues. And this is one of the pictures that a student shared, and the quote that came up. It's a picture of a clock, and this is a clock that ran out of battery the second month of school, and you always feel like you're going to run. So the power of that quote and sort of the picture together, when we went and sort of shared this information with who we believe are key stakeholders in the community, people that are trying to help keep these kids safe and healthy, I think that the picture and the quote together kind of move the conversation forward in a way that perhaps the people that provide counseling services, they're trying, but they may not be hearing really what it is. Another year, we were exploring sort of what the meaning of disparity was. A student took this picture, and it's a person who we presume is homeless, living on the street, and the quote is, they could be the same age as us, in their 20s or 30s, and to me they look like a Penn student. I mean, they could be one bath away from being a Penn student. Why are they not here, and why are they not going to school? So just asking people to think about what disparity means gave them this opportunity to look at their world, and perhaps they wouldn't have thought or known what was happening. So it opens up these opportunities for really rich content. So free listing. So free listing is an anthropologic approach where you ask people very open-ended questions. So what words come to mind when you think about managing your diet? What words come to mind when you think about bringing your child to the pediatrician? You generate a list, not narratives. You ask them to give you a list, and you have to kind of make sure they stick to that mission. The reason this is a great approach is that you can do a lot of it fast. And you can get 2 or 3 or 40, 50, 60 people to do this in about 5 minutes. And then you have a really wide swath of data that will allow you to appreciate some of the priorities in it. So the questions are simple. You can compare perspectives. You can decide to cut these data by gender, by race, by age, by all kinds of things to see if priorities vary based on that. You calculate for this work, you calculate salience. So you're not just looking at how often a term comes up among the constituents you've interviewed, you look at what rank it is. And there's been a lot of work on this that sort of says people naturally prioritize things when you give them a list. So you can argue that there's value in appreciating not only how often something comes up, but where people place it on their list when you. And the software to do these analyses are pretty quick. I'll tell you a little bit about a project we did with parents and pediatricians. The PI was Dr. Susan Levy, who's a big autism expert at CHOP, and she and I worked on a study sort of exploring shared decision making in the context of autism spectrum disorder, trying to get a sense of what parents' expectations were about shared decision making and what providers' expectations were about shared decision making. So we were asking both of them. This was not the only thing we did. We did free listing and interviews, but I wanted to just focus on the free listing because I think it can give you a quick peek and sort of an appreciation of what's happening. So we found for sure that parents and pediatricians had very different expectations about what shared decision making meant. Not a surprise, but hadn't been really documented in the literature before. They were really conflicting about alternative medicine and different other approaches to taking care of kids on the spectrum. There were definitely common barriers identified between communication barriers between pediatricians and parents really didn't feel like the pediatricians were prepared to help them deal with the stress associated with raising a child who was determined to be on. So Relisting interviews, we also did this work with folks at Children's Hospital of Philadelphia. Children's Hospital has a group of volunteer clinicians, nurses, attendings, and residents and fellows who go into the homeless shelters and provide pediatric care. Sounds like a really good thing. They think they're doing a good thing. Been going for years. But nobody really asked the patients or the potential patients what they would like from the clinicians that were providing them this service. So they said, we think we're doing the right thing, we think we're meeting their needs, but how can we get at that? So we did some interviews with both women living in shelter with children and with the volunteers that were providing services and with the shelter employees who were orchestrating and organizing those services to get a handle at what everybody thought they were doing and how it might matter in terms of that people needed. So it really allowed us to sort of see what were the different priorities. With the free listing, again, you're sort of looking at salience. So the things that were most salient to moms were things about hygiene, immunizations, sort of helping families keep appointments. They wanted help navigating the system. And the providers that were coming in really weren't thinking about that as part of their role, and that there was no one else that was really doing it for these folks. And the providers were looking to see about reassurance, teaching volunteers how to take care of patients, looking at their relationship with the healthcare system, and sort of encouraging healthy behavior. The staff in the shelters were looking for sort of easier ways to get patients the care they needed, and they're overwhelmed. I mean, they just have a lot on their plate. They didn't have a real good sense of what was going on. But what we thought was really interesting is the moms were really talking about herd immunity. They were not worried about their own child's immunization status. They wanted to make sure that everybody was immunized. They wanted to have a sense of what was happening and where everybody stood with all their vaccines and the flu vaccine and the whole ball of wax, because it was like they were public health students. They didn't use the expression herd immunity, but they were really all over sort of appreciating the healthiness setting. And one reason that we often incorporate free listing into some of the work, at least I suggested often, the work I do with clinicians, is they like graphs. I mean, people that have done quantitative stuff just really, really like to see a plot. So we're able to plot the salient score of the free listing data and get a sense of what are the most valuable things that have come up. And when you disseminate this work in different disciplines that have not become familiar with it, you really want to make sure that you're able to provide it in a way that's readily consumable and digestible. This is one of the things that informed the decision to do it that way. So we talked a lot about different individual interview approaches. I'm going to talk quickly about focus groups, as that's one thing I've noticed a lot of clinicians are interested in. So you want to consider a focus group when group interactions really make a difference, when you want to see what happens among a bunch of people. I like focus groups when I don't think I'll know best how to ask questions, because people living the experience can dig in a little bit deeper. And if you really are good at moderating a focus group, you get the participants to make the conversation happen in the way that's really, really helpful. It's not the best approach for everything. I was recently asked by some GYN surgeons if I would help them with a focus group looking at fecal incontinence. I'm just thinking that this is probably not a great focus group topic. Call me crazy, but let's do individual interviews and talk about fecal incontinence. And then, bringing it around the table just didn't seem like the way to go. So it's just one of the things that the topic has to really drive the decision. And you have to know your constituents. Not everything's off the table. People will talk about a lot of things in a focus group, but you have to be careful about what it is you decide. They won't talk about money often, interestingly enough. Lots of different health experiences, as long as they appreciate their commonality and common experience, you can get them there. I didn't think this was the best way to go. If you're working with different populations, it's the way to go, but some of the logistics can be really challenging. You don't want to do focus groups if people are, if you're interviewing CEOs from hospitals across the country, you're not going to get them all to come together to do this. Even if you were going to do it using some of
technology that would allow you to do it in a virtual space, getting people to have the same hour available is just not realistic. So you need to think carefully about the logistics as you make those decisions. And again, you'll have these as a sort of reference. But I think it's important that you want to decide between a focus group and an individual approach, but you really have to decide that it's not about which one is easier, it's which one is the best for the question that you're ask, and that might take some conversation with people from the outside. I think when you're in it and you're sort of in the thick of your own topic or area, it's hard to know what's the best way to take a look at it. It's always great to reach out and consult with someone who does a lot of this. And that's what's so fun about my job, is I'm working on all different projects. So I'm a methodologist and not a content expert. So I can't write the great discussion that has to go with the paper, but the method section and the results section we've got for you. So just talking to someone who can say, hey, here's a way to think about it, can be really, really helpful. So I encourage you to reach out to the people that have done some qualitative work and read some qualitative papers that you find in your own disciplines and see how they've handled it, because you want to be able to break into that discipline approach. And I think it does vary a bit by discipline. So if you want to use focus groups when the dynamic is really going to be important, or you're trying to build a group dynamic, you want to think about interviews when you don't care about consensus, or you're not trying to bring people together. So you do individual interviews for that, but focus groups for things that you really want to look at. And when the interaction between participants is really something that will illuminate the conversation. And I think we found that with our supermarket, because there was lots of conversation on at that table that, again, we may not have thought to ask. One thing to leave you with is that sometimes you have to do it a few different ways. You have to try multiple perspectives to really get at the best understanding of a phenomena. So it might involve free listing, might involve focus groups, might involve walking interviews, might involve photo elicitation, maybe more than one way to really. And some other things to consider when you do this work, whether you're going to do it in person or over the phone. There are great virtual ways to connect with people now. I've done photo elicitation work with a student, looking at the experience of people with diabetic alert dogs. So now they've trained, you probably know this, but they've trained dogs to sort of predict when your blood sugar is in trouble, and the dog will warn you and give you a clue that you need to deal with it. So we wanted to get a sense of how that having a diabetic alert dog impacted the quality of life for these. And the people that have diabetic alert dogs, they're not super common now. They're about $70,000 a dog. It's a big deal. They're all over the country. But there's so few people that have them, we did these interviews over the phone. So we explained the photo elicitation process, but because we can both be looking at the same monitor at the same time now, because it's magic the way it works, we could have these rich conversations even over the phone. There's different IRB challenges. The IRB is not a big lover of people not enrolled in the study and consented being sort of unintentional, accidental participants. So having people take pictures of people that haven't been consented, or having people walking interviews when other people may be heard. You have to know your IRB. You have to have those conversations with them. You have to point them to the literature, perhaps, if this is new or novel, to show them it's been done and done well. It's definitely tricky. The school IRB, I have found the single most challenging. The city IRB in Philadelphia is a bit tricky, but we've gotten some really interesting projects through that IRB. But you got to know your own group. You need time, you need space, you need skills, you need participants. Usually you need some incentives, you need some software to do this analysis and do it well, and you need to really appreciate whether your discipline is ready for you to disseminate this work and how you might best enter that discipline with work in this. And time, again, is a real. So quickly, once you've gathered data, I've given you all these different ways to do it, you have to do something with the data. And this is a long process. This could be another 2-hour talk. In fact, I have a 2-hour talk that goes over what you do and how you analyze it. But just quickly, you have to know the data, which is the transcripts generally that you've generated from all of these conversations. You have to open code those transcripts. You have to decide whether you're going to go in with a coding schema, a framework that you have ahead of time, or whether you're going to let the data kind of dictate that framework. It's a very very iterative process. It's not easy to sell folks that haven't done it on that. I mean, the radiologist I was working with on this paper, and I was like, yeah, you know, we need to go back in and look at these data again. She's like, why? You spit out the results. I'm like, no, you don't really spit them out. You kind of swim in them and try to understand them, but you can't do it alone. You definitely need someone to keep your biases in check. It's very collaborative work, very time-consuming work, but very rich, I think, informative work. And I don't think that qualitative methods trump quantitative methods. I actually do know how to do that too. But I think they together really can help paint a full picture of what's happening in really rich and important ways. So always safety first, and I never end a talk without this slide because I feel like it's important. So when I was finishing my dissertation, I was already like the oldest PhD student ever, and I had one more interview to do, and I had been chasing this woman. Sounds like I'm a stalker. I'm really not, but I've been chasing this woman for a while. She was part of a cohort. I needed to do this. She did me up 3 or 4 times, and I got to her house. And I knocked on the door, and she was there. I'm like, oh my God, you're there. That's great. I just having to do this interview, and you agreed, and blah, blah, blah. She said, sure, come on in. And I went in her house. It didn't feel good. Something wasn't right. And she shut the door behind me in 1,000 locks. It was like a scene from Saturday Night Live. It was cha-ching, bang, bang, slide bolts, chains, everything you could step on that held the door shut. And I said, hi. I was doing an interview looking at maternal health literacy and pediatric healthcare utilization. So we sat in her dining room, and there was a door in the corner with a little hook and eye, and behind the door there was a dog, and the dog was agitated and barking and growling and jumping at the door, and now the door's buckling because the dog is jumping, and at one point during the interview I could hear my voice get a little squeaky. The audio recording of this interview is hilarious, but it's since been destroyed, but I say at some point, so what kind of dog is that? She said, it's a Rottweiler. I'm like, oh, Rottweiler! Those are nice, right? You know, and I get really, really, really squeaky. And then she needed to leave the room because her kids were fighting upstairs. There was all this noise going on. No one knew where I was. No one would have ever found me. I'm alone in this room. The dog has now got its mouth out. It's drooling. So she came back down. I wrapped this sucker up pretty quick, learned nothing, gave her the incentive, but I never should have stayed. And I think sometimes we want to know so bad what's happening that this work does give you opportunities to take some risks. Like my student that's walking home with kids in really tough neighborhoods. You know, we're talking a lot about when to use your instincts to abort a project and kind of think about other ways of getting data. And this was a really dumb thing I did, so don't try this at home. So I hope this was helpful. Just a quick and really rapid overview, but I'm here as a resource for sure and happy. Yes.
This was fascinating. I really enjoyed it. Thank you very much. So for example, for the walking techniques, I mean, you need to have, I think you work with students, work with...
Yes, I do have access to a lot of students.
But you need to have a real good training.
You need to have a really good training. Yeah, you do.
So...
Yeah. And I think thoughtful people can do this work and do it well if they're reflective. So the way I do this work when I do it with students is I usually do one with them. Do one, see one, teach one kind of thing, where I do one with them, then I watch them do one, or if I can't be there to watch them, and Allison has had this experience, she did a really interesting interviewed transgendered women who'd been released from prison, talking about some of the barriers to re-entry. It didn't make a lot of sense for us to double team these women. They had been through a lot already. And, so she and I did some practice interviews. She did interviews with another student, and I observed. Then she did the interviews, and then we listened to the audio tape together and talked about places and ways she could have done the interview better. So it takes some time and training. We train people, and I train a lot of clinicians to do this work in the different disciplines that they do. They want to gather the data themselves if they have time, or they want to train their research assistants to do that. We run a course in the Mixed Methods Lab. It's like a 4-day intensive course where you can get some of this training. But it's not, I think if you're reflective, you can learn and learn well. I think what I tell everybody, and you guys have heard me say it, that if you listen to your own interview, you can find at least 3 places where you blew it. Certainly when I was getting a beating by the dog, I blew it a ton. But it's not like anyone's going to die if you don't ask the question well. Usually what happens is you're like, oh, I could have dug in a little deeper, I could have understood that better, or maybe I asked a very leading question. And writing good questions is really hard. People bring their questions to me all the time, and I'm like, oh, these are great questions. How about if maybe we say it like this, and work with them to write questions that aren't leading. And that's not easy, especially when you're really invested in something. It's like the IKEA effect. When you build it, you think it's great. That bookcase, it comes in a little box like this, and it's terrible. The books all fall, but you made it, so you just think it's awesome. That happens a lot with the way we write questions. It does take some time and experience. But everybody can learn, and I just think it's a matter of investing a little time. Very few of us who can't do this work well, I think, as long as we can.
So I've used Atlas in the past, and I currently use Learning in Vivo.
Uh-huh.
What software do you use, or what do you recommend?
I use In Vivo, and not because I think it's better than Atlas. It's just we have a relationship with In Vivo, and again, people, especially people that don't do this work, and you've got your hands on it, so they think the software does something for it. The software does nothing. I mean, what I like to say is that when I started doing this work, I would sit around with my colleagues, and we'd have copies of the transcript. And we would write all over the transcripts, and then somebody would say, you know what, I think we should rethink this code. And we'd have to go back and make new copies of the transcripts and start all over again and dig back in. Then they invented the Post-it note that you could remove. Like, this was a big deal in the qualitative area. It's like, oh, we could write these ideas on little Post-it notes. If we need to revisit it, we can pick them up and move them. It goes like, like the Nobel Prize in Post-it notes. Clearly, the software allows us to do really cool stuff, because I've worked on a project with hundreds of interviews. And we're able to, once you code and organize them in the software, you can query that software. Hey, show me what the men said. Show me what the women said. Show me what people talked about, their pain associated with their disease, and also fear and anxiety. Show me when those things have come up together. So the software allows you to organize your analysis, but you still need to read and think. And you have to be very transparent, but transparent with your methodology, I think, in these papers, especially if you're into disciplines that are not publishing this work religiously. I think it's one way to kind of get through that hump is to be very clear about how the data was gathered, who did the analysis, how you created this code book, this structure of how you were going to organize it. Super transparent. The code book itself and the database that you created in Vivo or Atlas or whichever one you use should live on its own. Like, somebody else should be able to pick it up and do the analysis and come up with the same findings. And that takes a lot of time up front, creating sort of operational definitions that are really very narrow so that everybody would think and read them and interpret them. So I don't think one software program's. I mean, In Vivo has a new version, and it just annoys me. I don't know, because it's got all these other bells and whistles, and they've just moved buttons around, and they charge us more, and I'm just like, man. I probably shouldn't say that on the recording. But, so, I think the point is that software, if you're going to do it, especially with any volume, you really need software. I mean, what we do with focus groups is so cool now, because we use something called Live Scribe. It's one of these pens that audio records, but it syncs the audio recording to whatever you wrote. So we can actually say, tell me what all the male participants said. We can cut focus groups by individual response, which is not something you were able to do before. Software really helps.
So how much time, I'm going back to the working study, how much time did it take to do this whole study? I think you had 20 participants. Right?
Yeah, so we had 20 participants. I mean, each interview, probably by the time you get there, talk someone into it, follow them around the grocery store, so that probably is a 2-hour window. And then the audio recordings need to be transcribed, use outside transcripts. We farm that out, bring it back. And then I would say with 20-hour-long, those are actually pretty short transcripts. Stopping trips vary. I'm not offended.
No, we're just listening to
Oh.
that.
I mean, it really depends on the length and the depth of the thing, but I mean, I think it takes us about, 20 hours to make a good code book. If we were to do it all in one sitting, you never do. You kind of do it in a couple of different things, but Allison and I work on a lot of different projects. We did one on traumatic brain injury with a colleague at the VA, and I think we made that code book. We each read a sample of the transcript together and had a conversation. We developed a code book, and And then probably for every transcript, it might take a good coder, someone who's savvy and knows the code book well. For 1 hour, how long would it take you to? A couple hours to code out an hour-long transcript. So it's time consuming. So 20 transcripts, at least 40 hours of a research assistant's time. At least some chunk of that should be looked at by 2 independent eyes. So you're going to double that, say, if you double code all of it, it's going to be 80 hours. If you do 60, then you got to write about it and, turn that analysis into sort of the results section of the paper. So it's not as quick, honestly, as quantitative analysis, spitting out tables and interpreting them. And having written about both of those things, this kind of writing, because you're trying to keep your bias in check, and that takes a little more energy. It takes a lot of time. I used to have dark hair. But neither do you.
How do you come up with the number of people before you do your analysis?
Oh, that's a great question, and I love that question. So, because we're not, worrying about power, we're looking for something called saturation in qualitative work. We're going to talk to as many people as we need to until we stop learning new things. So sometimes that can be more than others. So Allison's small study, a master's thesis study, she talked to 10 women who had been recently incarcerated, released, and navigating life post that incarceration. In terms of sort of reaching saturation with a novel new area, she's not there. She was still learning stuff. She just has to graduate. There's still a contribution in sort of understanding and sharing what she learned from those studies, but you want to go on until you don't learn more. For most of the studies, that usually is about 20 participants, between 15 and 20, you tend to reach saturation. You can reach saturation really quickly if you don't ask good questions. And that's the thing it's sort of a catch-22. If you don't do it well, you can be done fast. If you do it thoughtfully and really probe and try to understand more about what's happening, you want to go until you don't go anymore and don't learn. Money also dictates that time, and you have to. The IRB doesn't like, I'm going to talk to as many people as I need to until I learn. They don't like that. They want a number. So we tend to sort of always round up and say that we're going to try 40 interviews. We'll, stop if we're reaching that. Also, you have to think about what the most publishable number is. So one critique of this work is often, the N is small, the N is small. Well, it's not, we're not talking about generalizable numbers. We don't have random selection. We have non-probability sampling. These are convenient samples. So basically what we're saying is we don't intend to generalize this. We tend to shed light or amplify the experience of the person. And this is a contribution that you may be able to apply to if you're seeing patients like this too. And you have to be very careful with sort of overgeneralizing or pretending to generalize qualitative work. You see papers that sort of use that language, they're not doing it right. Because you can't possibly, you don't have the sample frameworks. The biggest study I've ever done was 111 interviews with homeless veterans all across the country. So there was a justification for sort of reaching saturation in different regions of the country. You wouldn't necessarily need that much because you would learn all you need to. Far fewer people, but there was a sort of a discussion that the experiences may really vary by state. In the end, they didn't. It's really not great to be a homeless veteran. They say much of the same stuff, regardless of what part of it. But we've done fun and really cool creative stuff. Allison and I are working on a project with a guy who's an artist. He's traveled across the country, and he does these art exhibits where he collects signs from homeless people, and he shows them. And I heard him on NPR, and I'm like, hey, really interesting. What do you do with those signs? Has anyone looked at the content? Could we think about doing some kind of real analysis? So we did a content analysis of publish it, looking at what are the different eliciting support. How does that help understand? In addition to all the quantitative papers that have studied homelessness. I always forget I'm being taped. So yes, I'm Italian when you watch this.
Great. Well, thank you so much.